The wake of the Titanic was perfect until it was too late to do anything about it. All the instruments were perfect. Everyone was looking, everything was going terrifically, but they weren't looking ahead. And I'm going to tell you about the future of healthcare. And I'm going to tell you about the future for two reasons. Firstly, because the future is not like the Isle of Skye awaiting our arrival. The future is like the Great Western Railway, something we imagine, plan and build. If we don't imagine, plan and build it, other people will. The second thing about the future, and this is the words of William Gibson, said to be a science fiction writer, is the future is here, it's just not evenly distributed. So everything I tell you, I can see happening somewhere, it's just not general yet. So, before, it is helpful to look at the past, and I find it helpful to think that we're in the third revolution of healthcare. The first revolution of healthcare was a public health revolution. Have any of you not seen the map on the right-hand side before? You know what that map is? It's the map of Soho. It's John Snow's map of Soho. And he didn't know anything about Vibrio cholera. He just worked out it was something in the water. Just as James Watt, that other Glaswegian, didn't understand the physics of steam. He just saw his mother's kettle boiling. That's what we believe in Glasgow anyway, that the Industrial Revolution came from empiricism. Now, in the last 40 years, we've had the second healthcare revolution, which has been high-tech, scientific. Joint replacement, chemotherapy, randomized trials. These are high science. And it's been fantastic. You know, Godfrey and I, in our professional lifetime, have seen the health service make an astonishing difference to the lives of people in a way that the previous 3 millennia had not made really any advance at all. So it's been fantastic. But at the end of 50 fantastic years, every society on earth faces these problems. Every society. Tax-based, insurance-based, co-payment, no co-payment, private, public. Structure doesn't matter. Structure doesn't matter. I've had about 20 reorganizations of the health service. Most of them have made no difference at all. In fact, I remember one where the chief executive said in the front of the Oxford Times he'd like to reassure GPs and the public they would not notice any difference as a result of this reorganization. Oh, nice to see you. Nice to see you. So, failure to prevent preventable disease, inequity, patient harm, even when quality is high, waste, and unwanted variation. These are the problems that people face. Germany, Italy, New Zealand, and even countries like Singapore, where there's growth in healthcare, these problems are there. And they will not be solved by more reorganization or changing the way you pay doctors, or they require more fundamental knowledge-based changes. Because this is what's coming. Here's the iceberg. Need and demand will go up probably 2% per year. 1% for population aging and 1% for new technology. Demand, well, we've got people here from the HECSI, so demand can be managed actually. Demand may not go up as much as it has done. Money will be constant. It may go up, I doubt it. And carbon has to be reduced. The carbon footprint of the health service will need to reduce dramatically by 2050, and that will be a bigger constraint because we use a lot of carbon in healthcare. So, let's think about the future. And the future is, and this is the work of Manuel Castel that has influenced me. He doesn't write about healthcare, but he writes about an industrial revolution, and he says that the future is, the third revolution is already happening. It's driven by citizens, knowledge, and this, the smartphone. How many of you don't have a smartphone? Do not have. You will. It's been decided. It's been decided. Who's decided it? Louise? Yeah. But who's decided it? Who's made this decision? Government? Or? No. Samsung and Vodafone. it's decided. And I'll tell you three things about these. Firstly, poor people have smartphones. I do work with single homeless people in London, helping my daughter as a volunteer. I don't do much practical, I help her get the money. About half of single homeless people have a connection with the internet. It's the most important thing in their lives. Secondly, poor people know how to use these phones much better than the middle class. And thirdly, the health service is about 10 years behind the times with the use of this. Why is it, you see, a woman said to me, that my hairdresser can send me information on my phone and the health service can't? The answer is obvious. The hairdresser's had 5 years of university education and 6 years of postgraduate training, so that's the reason the hairdressers can do it and the health service can't. So here we go with the revolution. Now, what I'd like to do first of all, because the evidence is that I'm reaching the stage where you're starting to drift, is to say, well, how is the 21st century different from the 20th century? So and this will be, I think, the 44th time I've done this, so I've got answers, not from myself, but from 43 other groups like you. So I'd just like to have a look at that. The square peg is unsuited for the round hole of the 21st century. What sort of key themes and trends do you see affecting healthcare in the next 40 years? Okay, I'd like to introduce yourself to your neighbour if you haven't met them, and I'll give you 3 minutes to come up with something. Okay, 3 minutes starting now. What are the big trends that will affect healthcare?
What do you think?
Good. Okay, 10 seconds to go. I've had a request to make the text bigger by the person who's the smallest writer, handwriting in Western civilization, Aunt Janie at the back. Hang on, let me... Okay, that's... have you got one trend you would like to?
We could know privacy concerns aside, where people are and about them,
yeah,
and do better planning in terms of age and other things.
Yeah. So it's we're going to be it's a knowledge network. It's different. Yeah.
People have more information available to them, but don't know how to interpret it, and often have bad information and
Yeah, yeah. So knowledge is the big issue. Yep.
Were you thinking that maybe you've used the phone to sort of monitor patients?
Yes. So it's a digital. The medical students I was with last night, the first thing they came up with was digital. They weren't quite sure what they meant by that, but they just. Well, a young person said at a meeting we had, when will the NHS get the message, my generation doesn't do envelopes? 12-year-olds don't have email addresses. You know, so we're just getting around that. We'll send them an email. They don't. Lots of 12-year-olds don't have email. Facebook and Louise.
You know, we talked about shift to long-term conditions.
Yes.
More self-management and self-care.
Yep. Yep.
Go through point by point and try to see what can change. For example, instead of focus on cure, hopefully more prevention.
Yes. Good.
The patient is more informed in general.
Yep.
We were talking about how information will be much more distributed, and it will be much more about how people share health information.
Yeah. Good.
We were talking about perhaps move away from paternalist statements and patients being more involved in that.
Yes. Good.
In fact, we were talking about the same thing,
Yeah.
the idea that healthcare should become consumer-driven rather than supply-driven.
Yeah.
Community is focused on hospitals.
Well, it's hang on. I'll have to read it out. If you like these slides, if you give your emails to Anand at the back, then we'll be very pleased to, if they're any use to you. So I'll just go through these. Patient-centered. The 20th century was the century of the doctor. 21st century is the century of the patient. The citizen is co-producer, is the jargon. I'll discuss co-production a little bit later. A focus from a cure to prevention, care and harm. I mean, the care is coming up now as a big issue, isn't it? Are people caring? So we're shifting. The last 40 years we've focused on the benefits of healthcare. The next 40 years are with a balance of benefit to harm. Equitable care for populations. Focus on systems and networks. This issue of sharing, it's a different sort of... the 20th century was the century of the bureaucracy and the hospital. The 21st century, the century of the system and the network. Driven digitally by knowledge. So knowledge is the thing, not money. Money is necessary, but not high carbon, low carbon, and challenges met by growth. Well, there's no more growth, so we have to transform. So, I'm just going to speak about a few things we're working on here in what we call the new paradigm, and I'll start off with value. Now, what do we mean by the word value? Again, turn to your neighbour and tell me what the word. What does high value healthcare mean to you? What's the meaning of the word value? Spend some 2 minutes speaking to your neighbour about value. How are you? Very nice of you to come. Because me too. Very well. Well, I said to Simon Curtis, well, I'm either in denial or I'm very well, so he's probably written down.
He's good, I guess.
He's very good, very nice, yeah. Who'd you go to?
Who do I go to?
If you ever go, stay away.
I go to the nurse. I don't go to the
Yes, me too. I told the nurse about the practice nurse. I said, the new woman Davis, she hadn't heard of the facilitator scheme. Oh, great, she said, it happened here.
Sheila Long is my favourite.
Yeah.
It's one of our other things we put on our list, changing demographics of healthcare. So, you know, more women, shorter hours, more nurses doing.
Yeah, so these are, we'll come on to those are, but this is in our the environment. Ken Birch always said when he retired, 4.2 GPs would replace him. In terms of, length of, number of people, maternity leave and everything. Okay, 10 seconds to go. Right, let's start. In the interest of equity, we start at this side of the room this time. Martin, I'm sorry, I don't know your... James, but what did the word value mean to you?
We thought it meant kind of that healthcare which kind of maximally promotes the good as
Yep, good. Okay.
For us, it meant I think the balance between return on investment for the community, quality of care for the individual, and respect.
Okay.
For the dignity of the individual.
Yeah, but there's a return on investment is a key phrase there, yes?
Also was more about like compassionate care and to have good access.
Yep.
We were a bit more interested about it, so this idea of getting as much as you can, but also at the right level
Yep.
for what you've got.
Getting as much as you can, that's what we've got to do, yeah? Yeah?
We were thinking about the quality of life of the patients, so again, patient-centered, so more patient-centered.
Back row.
I think we would
Oh, sorry, there are people sneaked in behind you.
Yes, we were talking about the efficiency of systems.
Efficiency.
Quality of the service for the patient.
Yep. Okay.
we were trying to balance up different layers of value, so value for the individuals, value for the health services.
Very good, good. Let's hold that there, yep.
I guess we were talking about maybe taking a patient-centered approach as everybody's values are different. So
Subjective, good. Yep. Yep. You go.
Okay, so we were also talking about efficiency rate, making sure that you get like right kind of like investment for the right kind of reason, and
Yes.
making sure there's no wastage. So like
Right investment for the right reason is good, yep. Oh, she's an insider, don't ask her.
Best outputs,
Yep.
outcomes for inputs.
Yeah, good outcome. Yeah, it's you see, values is a very this is the new paradigm now. Healthcare is always dominated by a paradigm. So from 1948, what was the paradigm? From 1948 on, healthcare is free. That was the paradigm. 1971 was it? Cochrane, 72, 70. Oh, when did Archie Cochrane publish Effectiveness and Efficiency? My wife says I mustn't point so much.
Okay.
Martin, when did
Okay.
Archie Cochrane? Mr. Cameron, what is the meaning of Magna Carta? He's the director of the Cochrane Centre, you see there. 71.
The book was about 71, wasn't it?
Yeah, let's agree it's
Yeah, very
71.
good.
71, yes, in 1971. And that led to the effectiveness paradigm. And Godfrey and I really have lived through that, which sort of morphed into the evidence-based paradigm. And then in the 1990s, along came cost effectiveness. And for the last 10 years, it's been quality and safety, following the publication of two big reports by the Institute of Medicine showing just how common errors were, and a report called Crossing the Quality Chasm. But now it's value. Now, value is a slippery word. Values in the plural, of course, means, you know, we value equality, we value respect, we value, so it's principle. But the economic meaning, which I'm going to be speaking about, firstly, you see there's a patient's perspective that we'll come back to, and we've got two people who know a lot about patient perspective in the room, and then the population perspective. Now, the first issue about the population perspective is allocative value. Are we maximizing value by the way we allocate resources? So if you look at that there, it's gastroenterology, liver disease, 4 billion, respiratory, 5 billion, cancer, 7 billion. Now I'm going to ask you a question. What's the expenditure in mental health? I'll get you to vote. I'll offer you three choices. 1 to 4 billion, 4 to 8 billion, or over 8 billion. Okay, 1 to 4 billion, hands up. 4 to 8 billion, hands up. Over 8 billion, hands up. 11 billion pounds. 11 billion pounds. Bit more surprise, isn't it?
yes.
What do we get for that, do you think? It's a question. I can tell you that the Royal College of Psychiatry Council couldn't answer that question. And of course, there's probably about another £5 billion worth of mental health problems in here. The sort of problems Godfrey faced in general practice of people with dizziness and terribly disabled, but then you see they're not quite where it's not. So there's probably another £5 billion worth of mental health with multiple morbidity. Now, the next stage then, and we're now expecting doctors to do this, is I showed this to medical students in London last night. I said, this is what you'll be doing in the future. The commissioners or the policy makers, they'll never understand the difference between how to shift resources from asthma to COPD or frail elderly. It's too difficult. The clinicians have to be responsible with the patient's organisations. I get the patient's organisations in the room. So I've called this within programme between system margin analysis. A young chap said to me, well, they want more resources for sleep apnea, what will I do? And I said, I'll tell you what to do. You get the asthma boys and girls and the COPD boys and girls and the sleep apnea boys and girls in the room and lock the door. I say, you people have to decide. And there's been some I published an editorial on this with a young colleague in the BMJ. The respiratory people have done this actually with COPD. If they want more resource for rehabilitation, the money comes from triple drug therapy. They're switching resources. And people are doing this all the time, but it needs to be more explicit. It will be tougher. Now, once the money's been allocated, the next type of value is technical value, and that's sort of return on investment. So you see, evidence-based medicine and quality and safety are still important because they determine good and bad outcomes, but it has to be related to resources, either money. For clinicians, time is a very important resource, because it's finite. So time is a very important resource. Or then we talk about opportunity lost. And this is what if I'm with clinicians, I say, well, look, if money is used in low-value activities, it's not the taxpayer who pays, it's other patients, because you can't have it. And I put carbon. Carbon's very interesting, and there's a Centre for Sustainable Healthcare in Oxford, run by some great young people, and they found when they went in the hospital ward, they said, oh, the hospital's got financial problems, and the people in the ward say, of course it's got financial problems, look at the idiots who are running it. But then you speak to them about carbon, and they engage. It motivates people. Now this is a very important principle created by a man called Avedis Donabedian, who I met once actually in the old Bank Hotel. People usually come through Oxford sooner or later. So as you put more money into healthcare, the benefits go up and then they flatten off. So one artificial kidney per million population, 10 artificial kidneys per million population, 100 artificial kidneys per million population. The trouble is, and this is classic, say, in intensive care or indeed statins, the trouble with healthcare is that the harm goes up in a straight line. So if you subtract the benefit from the harm, you get this J-shaped curve. This is Donabedian's brilliant insight. So there comes a point where the value is going down. Chemotherapy in the last year of life would be an example. Or quite a lot of care in the last year of life would be an example where more resources is not necessarily adding value. One of the things that we published an atlas of variation showing a huge variation in the proportion of people dying at home. And if they go into hospital and if we don't support general practice to keep them at home, then there's more and more resources used, but actually the value for the individual and the society drops off. Now, just coming back to the individual, and then I'll ask a couple of our colleagues from Hexia to speak. This is the diagram we've used since the start. We set up the Centre for Evidence-Based Healthcare, Centre for Evidence-Based Medicine, about 15 years ago now in Oxford, that a decision has three factors. The patient, I'm down to the individual now. The individual patient has three factors: the evidence, the clinical condition of this patient, because the evidence is often derived from studies of, for example, I think the famous heart failure, there are studies done of treatment for heart failure, but in general practice, I think it's 3% of people only have heart failure, so the evidence has to be related to other things. And then the values that this patient places on the benefits and harms. So here you see, as you do more health care, let's take cataract operation. So you start off here operating on people who can hardly see. I mean, if you go back 10, 15 years, Godfrey, people's lives are transformed by cataract operation. But now we're doing maybe 8 times as many cataract operations. So you go along to the optometrist, oh, a bit of cataract there, on the waiting list, into hospital, you'd like a cataract operation, oh, it's a wonderful thing, a cataract operation. But 1 in 1,000 goes wrong. So the offer is different. That's why I don't go to the optician. These are these were €3.50 somewhere in Italy. I usually put them on when there's ophthalmologists and optometrists in the room because they know I don't go along to the. I just have short arms. That's the problem. He says I don't need to go along with. But our hip knee replacement, these are. So we're very lucky in Oxford. We've got some of the best centres in the world thinking about this, and just asked two of our colleagues. So we'd like to say a little bit about Hexie and Louise a little bit about the decision making and the patient's values and experience.
Louise can say more about Hexie.
Well, yeah.
Okay, I'll say a bit about Hexie,
Yeah.
which is the Health Experiences Institute, where we're trying to bring together different types of research into patient experience. And it's come from what we work on, which is qualitative interview studies of people's experience, and working with colleagues who work on more quantitative measures, and trying to bring those different sources of evidence together and then look at how we can change practice as a result of that. So I suppose my issue with the kind of evidence and patient perspective is that I think they can be one and the same thing. That patient perspective is a type of evidence.
Yeah, sure, yeah.
That's why.
Yep. Yep.
I think that too.
Yeah, going back, I think I should maybe have done that when we invented the word evidence, which, but then in some senses you have to oversimplify, so I oversimplified at that stage. Yeah.
So when you ask people to talk about their experiences of health and illness, you often find out things that you never would have suspected, both on a collective research level and on an individual level. And there's a lot of interest now in looking at patients' preferences as what family and others have described as the silent diagnosis. We make all kinds of assumptions about what people might want in terms of treatment. And you go see them, we're as one, aren't we? It's amazing. Yes. So if you ask people, you're often surprised. And we ought to use that surprise to shape the questions we ask and the way we deliver services. Crowdsourcing.
See, maybe that we are going to go, Maureen Bisognano, who's the director of the IHI, has got a lovely phrase, we may move away from what's the matter medicine to what matters to you medicine, and go back to really problem-oriented, what is the problem, which again is one of the strengths of general practice, is focus on the problem. And actually in this room, Anand and I ran a workshop on elective surgery, and Andrew Price from the Nuffield Orthopaedic, the discussion we had, what business is the Nuffield Orthopaedic Centre in? Is it in the knee replacement business, or the knee arthritis business, or the knee pain business, or the gardening business? This woman came to see him, and Andrew said, well, what can I do for you? And he said, I'd like my knee replaced. And he said, well, why do you want your knee replaced? And he said, well, she said, I love gardening, and I'm finding it very difficult bending. And he said, do you realise if I replace your knee, you won't be able to kneel at all? And she said, no, I didn't know that. Thank you very much. And went out. So, the problem was the gardening, but in some way she'd got into the system, and she'd read about knee replacement. So this issue of focusing on the patient's problem, and this is this nice idea of the silent. Can you read that, Anand?
I can read it.
Yeah, okay.
The reference is
See me later. Now, so that's the first issue, value. I just got my eye on the clock, the most important thing in any lecture room. The second issue I'd like to speak about is systems. And this is a major part of our work, is developing systems of care. So the 21st century is the century of the system. And it helps us deal with what we've called the healthcare archipelago. And that's the healthcare archipelago. £6 billion, £11 billion, £60 billion, £10 billion. The occasional ferry boat plies between the islands, but they've been largely unchanged since 1948. The contracts we give are based on these. One group of people gives GPs contracts, another group of people gives contracts to hospitals, another group of people gives contracts to hospital services. I said once to some people, I said, well, what does the hospital do for arthritis? You know, what do they get you? Oh, we don't know. They said, we just give them £240 million a year. You know, a big slab of money given to the hospital. About this stage, if you were clinicians, some of you are, but you know, if this was out in, where was I last, in Herefordshire or London or somewhere, I'd be saying now, from now on, we ban the use of the words primary, secondary, acute, community and outpatients. These are banned words. We're not going to use them. And these are 20th century words or 19th century words, so we don't use them. And we're going to move on to look at this. This is what care is like. Self-care is the most common type, then friends and family, then generalist care, then specialist care, and sometimes super specialist care. Now, for broken legs, you see, it's not a problem. If you walk out there and get run down, you don't need a good GP or the right health beliefs or right values. I mean, you'll just finish up the right place. Cancer, you usually finish up the right place, maybe too late, but you know, or unnecessarily late. But with joint pain or headache or dizziness, then the distribution across these different types of care doesn't maximize value, doesn't maximize the return on investment. So here, if you take people with long-term problems, so some of them are getting the specialist service, but the people who really benefit most are not the same ones, and some of the people getting the specialist service aren't necessarily the ones who benefit. GPs in Oxfordshire, for example, with this discussion, I don't know if you were there, we had a discussion about breathlessness. So you're offered, I think, still a cardiology service or a respiratory service. And a GP, I can't remember who it was, said, oh, I referred this patient to cardiology, and I got a letter back saying, oh, he breathless, didn't really know. I got a letter back saying, negative MRI, negative stress test, negative ECG, suggest referral to a respiratory medicine. Well, you know, you knew that, but just the machine offered you these incompatible sort of options. So we need to move on to systems thinking. And we've been trying to do this, and Godfrey and I were developing systems a long time ago. I did it with Claire Parker, Sally Hope. Sally retired last Wednesday, I think, or 2 weeks ago. Trying to look, well, how is heart failure managed? What is heart failure? They went out to look for heart failure, and they came back, and they said, well, the only thing we would find in common was these people getting diuretics. You know, we don't really know what is this thing. So even the fundamental definition of the scope. This was something I wrote about many years ago. 1983, Godfrey published this in The Lancet, saying we should run the whole of healthcare in systems, frail elderly people or pelvic pain or asthma, with budgets that way. And I showed this article to somebody last year, showed him the date. He said, 1983, oh, clever, you wrote that in 1983, it's fantastic. So I rushed and showed it to someone else, and I showed him the date, and he said, 1983, what the fuck have you been doing for 28 years? And the answer is waiting for the money to run out. My experience has been, when Mrs. Thatcher was in, that's when we did a lot of things, because there was no more money. You've got to think, you know, you've got to do things differently. And the last 10 years, really, we have been sort of wilderness years for people like myself, because there's 4% more growth. The specialists aren't interested in talking to you about fundamentally, they just want to get their hands on additional money. The National Audit Office report on neurological conditions, worth looking at, it says that the expenditure in neurology went from 2.1 billion to 2.8 billion, but we cannot find any evidence what the result of that was over a 5-year period. The money is, the inputs, who used the word inputs? I think someone here used the word inputs, just went like that. But what's the outcome? Yes, you talk about inputs and outcomes. So urology, there was £700 million a year poured in, but we're not quite clear. So now these are words you can use. System network pathway program. And here's a system. Here are the questions that we need systems. So this was from, I was in London, And you see, we can't answer these questions anywhere. Is asthma care better in Somerset or Devon? Don't know. Is epilepsy care better in Leeds or Sheffield? Don't know. I don't think, Godfrey, we can answer the question, is colorectal cancer outcome better in Manchester, Liverpool, even for the money because we don't start with the system. We don't start with the system. So these are questions that we have to. We can tell you, is the care in this hospital better, or which GPs are doing more of this? But we don't have these population-based, these value. We can't answer these value questions. And this is what a system looks like. I'm sorry the print's small, but this is other language: objectives, criteria, standards. Objectives, criteria, standards. Now, I'd like you. And I'm watching the clock because I don't want to go on too long. But let's. I'd like you now. I'll give you quite a simple problem. Asthma, because most people have got asthma, only have asthma. Well, it's not like type 2 diabetes or something. So it's relatively. I'm looking at the GP here, but we spend £1 billion a year in asthma. Okay, so now we've appointed you as the board of the asthma programme for England. So what are the objectives of the asthma system? Okay, work in pairs. Just give me an objective. What are the objectives? What are we trying to achieve with asthma? No, where's he? Sorry? Oh, yeah.
Last time, the drinks are here from 7 and we're expecting to be here from 7:30 in the room. In this
Yeah, I'll finish about 7.
yeah, that's good.
Quite enough.
In the shorter terms, people who have it to lessen their pain or sort of it seems like there's maybe urgent.
10 seconds to go. Just objective. You do the criteria and standards if you. That's 4 minutes. We'll give you 4 minutes. Okay. Back row. One object, just one.
Reduction of harm.
Yes. Yeah. Louis?
We were having a bit of a radical thought about whether you should be screening for asthma.
Okay. To diagnose early, where you could
Yeah.
express it, whether it's screening or not, yeah?
About prevention and
To prevent asthma, yeah. Good.
Well, one of them was to reduce the number of people whose conditions deteriorate.
Yes, yeah.
Supporting research, particularly in that direction.
Okay.
Improve the quality of life of every patient with asthma.
Okay.
We thought we'd like to keep them alive and avoid sending them to hospital.
Yes.
Reduce total periods of breathlessness for people with
Yeah.
asthma.
our objective was education and providing more information to people with or without asthma.
Yeah. Okay, these are, this is what a group of asthma specialists come up with to prevent asthma, to diagnose asthma quickly and accurately, maybe by screening, to slow the process of the disease, to help the individual afflicted, and to involve patients. But it's quite good. You get 5 out of 10. But here's another 5. To make the best use of resources. You know. So we want you to sign up to make the best use of resources. Not just to say, oh, we need more money. It's you're now running asthma, so you're responsible for the resources. To mitigate inequity. Where are the? Did you come up with that? Did you? She came up with that, did she? Yeah. Yeah, you say we want you to look at where children are referred from, and wasted resources could be spacers. I think of £1 billion. If you and I were running, we'd probably take 50 million out, could we not? I mean, the use of spacers, bad use of spacers. Plymouth is going to take £2 million out of Plymouth alone and put it into COPD because they think spacers have just. What's your view on that here?
Well, I think if you're getting sometimes spaces are very useful.
Mm-hmm.
It's very dependent on the individual.
Mm-hmm.
If you're not delivering the drug to the airways,
Yep.
then you're wasting the drug.
Yeah.
Inappropriate spaces.
Just from our interviews on people with asthma, actually, that poor inhaler technique is one of the big things.
Yes.
People don't know they're using.
Yeah. Yeah. So the.
Why do you want to get rid of these spaces?
Pardon?
Why do you want to get rid of the spaces?
I ran a workshop in London, and the respiratory physician from Plymouth said, well, they'd come to the conclusion they would not get rid of them. They thought it was a combination of overdiagnosis of asthma and prescription of expensive spaces without proper education, and he thought he could take £2 million out of that and put it into rehabilitation and COPD. To promote research, Marisha came up with that, but she's a pro at this. Oh, you did good? Yeah. Good man. To support the development of staff and then to report annually to the population served. Write a report. I say, how many asthma services should there be in England? And a GP said, oh, we all have an asthma service. I said, we have an annual report. No annual report, no system. You have to have an annual report. And systems are delivered by networks. So in the 20th century, it was professor, consultant, GP. 21st century, professor, consultant, GP, pharmacist, nurse, patient. The network society. This is the, someone said, I think, you mentioned the word network or sharing. This is partly driven by technology or facilitated by technology. And then a pathway. This is the pathway most people follow. I'm not saying you all should follow it. But with the change in staffing in the health service, we have to write things down much more. This is a point this group raised, that when I came to Oxford, there was one rheumatologist, and there were 4 GPs in Headington who'd all been there 20 years. There are now, I think there are now 10 rheumatologists, because 2 more have come from Southampton, and the same practice in Headington has got 12 part-time GPs. So you have to write things down more than we did. Now, let's come on to just finish with the patient. This is something I was involved in launching with a young doctor called Neil Bacon, and it was allowing patients to give feedback. Now, this is much simpler than the Hexay, but it would be just, people should be able to give feedback. Everywhere I go, I'm given a card from Starbucks and things. What do you think of the service? But we got hate mail from the BMA like you can't, well, you could imagine, I'm sure. But eventually the young doctors we're working with say, yes, great. When I go for a job interview, I will be able to show 30 reports. And what we've got built into this, there's all sorts of things in the software that you can't send 2 messages from the one computer. Because you can easily run a vendetta against a doctor, but with this system, you can't, because there's a whole variety of issues in here. So there's one example. And we're now increasingly, I'm working with patients' organisations. So if you take this issue of, say, epilepsy, how many epilepsy services should there be in England? My own view, maybe about 30. Because epilepsy, although it's very common, you want to know it's focused on neurosurgery and referrals. So you might want a big population. And I know from my own experience, if you go from the Ministry of Health and say, oh, we need a big network, they tell you to get lost. But if the patients' organisations go, then they've got moral authority. It's quite different debate when you've got the patient organisations involved. So I'm working a lot now with big patient organisations. I tell them, no more money, just for the next hour and a half, let's not forget about campaigning for more money. And they say, okay, yeah, that's fine by us. We can see waste, we can see how things could be better. So patient organisations. Now here's an example of 21st century healthcare. Imagine I've got FH. I don't have familial hypercholesterolemia, but See, FH is an interesting condition. We spend hundreds of millions of pounds on people at low risk of heart disease, but we've only identified 15% of people with familial hypercholesterolemia. Just, you know, no, it's Brownian motion, the random movements of patients, professionals, blood samples and reports. That's what most of healthcare is. So here's the lab report, and I haven't got the Oxford Lab Service to do this yet, but so it says, here's my lab report. You see here, the GP receives a copy of the email. Why should Godfrey, who was my GP, why should he be responsible for my cholesterol? I should be responsible for my cholesterol. He can be informed, but it's my responsibility. Now, if it's methotrexate, you know, which is a pretty poisonous drug, maybe the GP should be more responsible because I might be lying exsanguinating at home. But for the patient should be responsible. You know, it's, so here's the lab. It says here, cholesterol is unchanged. No need to increase statins. The first step to increase the amount you walk an extra 3,000 steps. Have you ever considered buying a dog? It also says here, this test was done 12 months ago. If you do it again, we'll throw it out. For access to full text of guidance, click here. To test your knowledge, click here. So you see, if I had a big dog, click here. You see, the lab knows my postcode, and you put in Google, buy Labrador OX2, and that came up. It's sweet, isn't it? It's a lab test, a lab result. You see, the health service sends out 600 million of these a year, and I've never seen one that's got really useful information in it. We send out 1.5 billion letters a year. And there's, what do you put in your letters, Martin? You put links to little YouTubes of you? No. So easy, you see. The hairdresser does it. So we give 600 million prescriptions, 600 million lab tests, and 1.5 billion letters. And because that's when people are interested, you know, when they get a letter. So there's no point in telling people, oh, go and look at the internet and learn about health. It's when you get a letter saying, please, you're booked in for electrocardiogram or a step test. So we will do this. This is this is a very simple thing to do. You see, you could just change Microsoft Word so there was a link. So if someone's typing the word myxedema, they don't need to ever have heard of it. They're just so this is and it's impossible, you see, to do everything in the consultation. And those of you who do consult, how much time do you allow for your consultations now?
I've given up in 10 minutes.
Have you?
So, I have catch-up periods.
Yeah.
So I have 4 10 minutes and every 20-minute catch-up.
But it's still, you see, the emotion in the consultation is so great. I'm very influenced by one study in Nottingham which showed not only could patients not remember what had been said to them in the consultation, they couldn't remember whether they'd asked the questions they meant to ask. You know, just the emotion is so great. So what we've got to do is before the consultation, after the consultation, and surprise, surprise, people are up for it. At this point, usually someone says, not an enlightened audience like this, someone says, oh, I can think of a patient who wouldn't do it. Yeah, well, I can think of 30 million who would, so let's start there. It's, so often people are, they think of one, oh yes, oh, no, it's rubbish, you're talking rubbish. And then doctors also say, oh no, I don't want information myself. But of course, the docs know how to work the system. They choose the doctor. And then I say to them, supposing you got ill in Bucharest, what do you do? Well, I'd be on the internet like a short. So doctors are not typical. They choose the clinicians on the basis of knowledge that patients don't have. So just to finish, because the theme is knowledge, and I'm just showing you, this is a sort of, this session, this is Oxford University, you know, you're very bright people. I'm not an academic. I try to work academically, but I'm not an academic. But what I've done, this is pretty much standard pitch for me if I'm in Bedford on a wet Thursday evening with a lot of battle-hardened GPs and patients in the room, or medical students last night, or next week it's a lot of clinical scientists and also a bunch of pharmacists wondering what's the future of pharmacy. This is our story. Merenisha's working with me in Anant, partly I work half-time for Her Majesty and half-time for my own little organisation called Better Value Healthcare. So I'd just like to finish with the knowledge. So this is the sort of knowledge people get in most places in the world. This is what they should be getting, clean and clear. So when you're in the knowledge business, as I've been for many years, this is Loch Katrine, which provides Glasgow's water, which is very much better than Oxford water. And it's a reservoir, like a library. Why do we have reservoirs? What's the function of a reservoir? Buffer supply and demand, and? Yes. There's another very important function. It's to let the rubbish sink to the bottom. You see, if a sheep dies and rolls in, it just, ultraviolet light on it. And the sort of thing that Martin and I are involved in, most randomized control trials, you should not act immediately on the latest evidence, because what percentage are invalidated within a year, a half or something, yeah. So we don't need to react all the time. You hold it back. And then what you do is, this is a picture of the Cochrane collaboration, or NICE. This is a filter. So it comes in here, research reports come in here, and stuff come out there. So that's the next. And so Martin runs the Cochrane Centre, and that's part of a big filtration system. And then this is, then we've got the internet. And this is a picture of the internet. Internet's big tubes up in the sky. You can't see them, but it's must be. I don't know, how does it get here? There must be big tubes up there. This is the Thirlmere and Aqueduct Society. Must be a lot of sad men, I think, sadder than me. They preserve these pipes. You don't do that at the weekend, Louise, do you? So this is the internet is fantastic, but the internet only gets it to it gets it to the hospital. But how does it get on the ward? How does water get on the 5th floor of a hotel? You go into a hotel up the 5th floor, you turn on a tap. What's the water's coming in the pavement? It's not coming. So how does it get? Why does it come out the tap? Pipes. Yeah, the pipes, but pressure. Where's the pressure come from? Where? Where's the pressure come from? Pumps. No, not usually.
The reservoir is higher up.
No, that wouldn't do it in most places. Have you not seen the Towering Inferno, any of you?
There's a tank on the roof.
A tank on the roof, that's it. Maybe they don't know about the Towering Inferno, these young people. Yeah, you have to watch the Towering. It's a tank. I thought a picture of a tank. Yeah, there we are. It's a tank. So at the top of the hotel, there's a tank. And what we did is we created the idea of a chief knowledge officer, someone in every healthcare institution who was responsible. Ian Chalmers defined it as, we said it's a role, not a job. I was chief knowledge officer for the NHS, and I didn't have any resources apart from authority to say, I said to NHS Choices, well, where are you getting your knowledge from? Pressure. So Ian wants to find it as, who is responsible for saying to the chief executive of the hospital, there are 3 new things in the Cochrane Library this quarter. Sort of everybody's responsible, but you've got to manage knowledge. And this is the phrase we've used over the years. Ignorance is like cholera. It cannot be controlled by the individual alone. It requires the organized efforts of society. That's the definition of public health. So to finish, this is the way we see things, that we've tried bureaucracies and markets to run healthcare, as has New Zealand and Australia and Canada and everywhere else I know. But what we're trying to do is too complex. So you need a complex adaptive system. And the best example of a complex adaptive system is the leafcutter ant. You see, ants aren't a bureaucracy. Any of you experts in ants? Maybe bees are pretty clever too, but ants are cleverer than bees. They're very adaptive, when twigs drop across, so they have their jobs to do. They communicate with one another all the time, and they work for the good of the colony, not for the individual. The selection is at the level of the colony. So this is what I usually finish with. It's very interesting after a meeting, the clinicians come up and say, you see, we've created a health service in which The GPs have been over here and the specialists over there. I heard last night actually, and I'm going to take action on this. I was with these medical students last night, and there were some very good people there from hospitals in London. And this doctor said, well, in our hospital we're signing confidentiality, gagging clauses. We mustn't speak to people in other hospitals. Well, they're working for the National Health Service, and we need to do something about it. So, ladies and gentlemen of Bedford, you're in it all together. There are no more resources, so we have to work together to do it. So, Martin, that's our approach. There's many people in this room with whom I've worked, notably Godfrey and I set up a system in general practice many years ago, 30 years ago or something. So these are systems thinking, systems, network, pathway. We have to produce more value from the resources we've got, because there aren't any more. And I think if I were offered £1 billion, I'd probably put it into primary education and not the NHS, for example. So we can't just assume that if there is more money, it's going to go into the health service. Martin, thank you very much.
Thank you.